Long case, mitral regurgitation. Mr. Jamaluddin, 30 years old farmer, non-diabetic, normotensive smoker, hailing from Jamalganj, Sunamganj, was admitted into this hospital on 10th August 2022 at 11 am through outpatient department with the complaints of increased shortness of breath for 1 month and palpitation for 1 month. According to the statement of the patient, he was reasonably well 3 years back. Then he noticed shortness of breath during heavy exertion like working in peripherals, carrying heavy goods, washing clothes, doing household works hurriedly, and it was relieved by taking rest for a while. This shortness of breath is progressively increasing in nature. Now his shortness of breath has got worse for last 1 month, which occurs during mild exertion such as doing daily activities like walking at home, bathing and dressing. Now it needs prolonged rest for improving his shortness of breath. He has repeated history of sudden awakening at midnight due to breathlessness for last 1 month and needs to go to the window for open air and it improves after 10 to 15 minutes. He has no history of difficulty in breathing during lying flat. His shortness of breath is not associated with cold, dust, fumes, taking drugs or food or any exposure to allergens. There is no diurnal or seasonal variations. He has also complained of palpitation for 1 month, which he feels regular in nature. This palpitation occurs with mild exertion. He had similar type of recurrent palpitations for last 3 years which occurs with severe exertion and improved with taking rest. This palpitation is not associated with taking tea or coffee. Anxiety, depression, chest pain, dizziness, lightheadedness, transient loss of consciousness, increased frequency of micturition, vertigo or vomiting, weight loss or loose motion. He has also history of occasional cough with frothy sputum production with increased shortness of breath for last 1 month, which was improved with taking rest and some drugs. He gives no history of chest pain, recent onset of fever or prolonged unexplained fever, swelling of legs, abdomen or neck swelling, skin rash, joint swelling, joint pain, weight loss, increased appetite or hand tremor. He denies any complaint regarding hoarseness of voice, difficulty in swallowing, focal weakness of any side of the body, or any history of accidental chest trauma. On query, he does not give any history of significant sore throat, fever with joint pain and swelling during his childhood, which is suggestive for rheumatic fever. He has no history of known ischemic or hypertensive heart disease or any known congenital heart disease, diabetes mellitus, asthma, COPD, childhood recurrent respiratory tract infection, tuberculosis or contact with a known TB patient, and documented COVID-19 infections. His bowel and bladder habit is normal. With these complaints, he had consulted with several physicians, and after evaluation, they have said that he has some sort of valvular heart disease, but he could not mention the name of his disease. He is taking some drugs for last 1 year irregularly, but could not mention the name of the drugs. He had never admitted in any hospital for his illness, and he had never undergone any invasive procedures. He is immunized as per EPI schedule and got all doses of COVID-19 vaccination also. He is a smoker, smokes 10 pack yard, non-alcoholic, non-betel nut chewer. He is married, has 3 children. He has 2 brothers and 1 sister. His parents are alive. All of his family members are in good health and none of them have any similar type of illness. There is no family history of sudden cardiac death. He has come from low socioeconomic condition. He is a farmer and one of the major earning member of his family. On general examination, patient is looking ill, body build average, cooperative, decubitus on choice, pulse is 110 beat per minute, regular in nature, small in volume, no radioradial or radiofemoral delay, condition of the vessel wall is normal. All peripheral pulses are present and symmetrically palpable. Blood pressure is 100 over 70 mm mercury in both arms. There is no postural drop. JBP is raised 6 cm from sternal angle and A wave is prominent. Respiratory rate is 18 breaths per minute, normal in character. Temperature is normal and periphery is warm. Patient is not anemic, non-icteric, non-cyanosed, non-dehydrated. Leg edema and sacral edema is absent. There is no clubbing, leukocythemia or koilonychia. There is no thyromegaly or lymphadenopathy. Hair and skin condition is normal. There is an IV cannula in situ in left forearm. On precordial examination, apical impulse is visible and seems to be displaced downwards and laterally. There is no chest wall deformity. Size and shape of the chest is normal and there is no visible scar mark. Epigastric pulsation is seen, but there are no visible suprasternal and supraclavicular pulsation. Apex beat is located in left 6 intercostal space lateral to the left mid-clavicular line 11 cm from midline. Diffuse in size more than 2.5 cm is felt over left 5th and 6th intercostal space. Forceful and ill-sustained, that is thrusting in nature. There is presence of systolic thrill over the apical area, best appreciated with the patient in left lateral position. Left parasternal heave and palpable P2 and epigastric pulsation is present. First heart sound is soft. Pulmonary component of second heart sound is loud in pulmonary area. There is a loud, blowing, pansystolic murmur in the apical area, grade 4/6 in intensity. Best heard with the patient in left lateral position with breath hold after expiration with diaphragm of the stethoscope which radiates to the left axilla. There is also an audible loud third heart sound in apical area. There is also a pansystolic murmur in the left lower sternal edge with grading of 3/6 with no radiation, which used to increase in intensity with breath hold after inspiration. There is no other added sound. Lung bases are clear. Other systemic examination reveals normal. This is all about the history and examination findings of my patient. So my provisional diagnosis is severe mitral regurgitation due to chronic rheumatic heart disease with pulmonary hypertension with sinus rhythm with NYHA class 3. Thank you.